How can drug therapy be monitored? When we talk about monitoring the drug therapy, how can drug therapy be monitored? First, we all what we care is how patient feels and functions their body. And this is in the case of epilepsy, this would reflect the seizure control and no toxicity. This is the goal we all look for when we treat our patient, in addition to seizure freedom. The AED blood level monitoring has been routinely used since the advent of reliable assay of phenytoin in 1960. And the TPM initial study was started by Bockthal and Steven Smart group in 1960s. And the concept of the drug monitoring rests on the assumption that drug concentration correlates better with the clinical effect. So we assume when we monitor the blood level that this is the concept. And as you guys know, never assume the obvious is true. Never expect, never assume, never ask, and never demand. Just let it be, because if it is meant to be, it will happen the way you want things to be. So the goal, never assume. So if it is photo, assume nothing. This is more of a dolphin stress test. Now, what are the requirements I need in the drug to, for this medication to be perfect for measuring the blood level? First, the drug has to have a reversible action. The drug has to act per se and not through the metabolites, and there should be no tolerance, and we will talk about the medication that have tolerance, and the blood level should highly correlate with the blood concentration at the receptor site. And there should be a clear relation between the efficacy and the blood level. Now, the therapeutic range, the term suggests that good level equal good control, low level equal poor control. And we know that this is not the case, especially with the newer AED medication. So instead, we will refer to it to the reference range. And the reference range is the range of a drug concentration that specifies the lower limit, below which it is relatively unlikely seizure control will happen, and above which, and the upper high level, above which the toxicity is relatively likely to happen. We are talking about relativity. Now, concentration in the reference range are not normal. All the time we say it is normal concentration or reference level, because the normal concentration in normal human being should be 0. And the best indicator is this clinical seizure control. And always we have to remember that it's a guide for therapy, and it does not dictate by itself what should you do with the patient. Now, what are the challenges and limitations of the therapeutic drug level in anti-epileptic medication? We think that rules and TPM are written in stone, which is not the case in most of the cases. And they will go through the history, and they will also go through the studies that were done before to tell you that what we think is really written in stone is really not written in stone. Now, the seizure occurs at a regular time. Sometimes it takes really long time, 3, 4, 5 months, for the seizure to occur, with or without medication. So in order to see the efficacy of the medication, you might have to wait 4 or 5 or even 6 months. Some anti-epileptic medication will produce a side effect that you cannot differentiate between the side effect and between the disease itself. For example, the neurodegenerative disorders. And there are more simple lab tests that will tell you that the medication is efficacious or not. You have to wait clinically and see. EEG might be a little helpful. Now, to complicate the process more, the patient can be seizure-free and have a low blood level. The patient can lack toxicity and have a high blood level. We see this all the time. Patient can have serious side effect with low blood level. So many evidence supporting the efficacy of this medication were done in a patient who are really difficult to control. And moreover, each patient represents a single dose response curve in regard to medication response. Now, so some author, they suggested, okay, let's go ahead and omit the low level and put a threshold, or leave the threshold for each doctor to decide where the patient would cease. Those adjustments should never ever be based only on the drug level. Treat the patient and don't treat the lab. And dosage should not be modified in patients who achieve seizure freedom, either on low level and nor in the patient who are doing clinically well at concentration above the high range. I'm going to take time out here and tell you my experience. I worked with two outstanding physicians in the States. And I will tell you two stories, how as a physician, many times, we use the therapeutic drug monitoring in the wrong way. One of the physicians I worked with, which is, I think he is genius. If the patient is seizure controlled for 1 or 2 years and the blood level is below the lower normal level, he would say, okay, the medication is not working, this patient is controlled, stop the medication. That's one, and we know this is not the right way to do it. Another physician who is very well known, every time we ask him, you know, doctor, this patient has been seizure free for 10 months or 2 years, but his tabacine level is low, he will tell, if you're going to put the patient in a poison, you better keep him in the therapeutic range. So it's really important to understand what's the concept behind TDM. Now, why sometimes when you give a patient treatment who is seizing, you will have a happy camber, the patient is seizure free, no toxicity. While in another time, you give a patient a treatment and he will get worse and he will never be controlled. Or sometimes you give him the treatment and the patient could go à la casse or die. Why is that? This is secondary to what we call pharmacogenetics, which is genetically controlled variation in drug response. And this is what we call genetic polymorphisms. And this is, you know, this can be secondary to difference in pharmacokinetic, dynamic or idiosyncratic response. So every patient responds to the medication in a different way. Now, is it true the gene dictate what we do? Is it because some people, is it the gene telling us to drive slowly in the left lane and not use the right turn signal? Is it the gene who will tell some people to be the propensity to discuss weather? Is it the genes who make some people like to talk about movie all the time or not? One of my attendings used to tell me, if you see something not right with the patient, it's only his genes. But we are not able to discover till this moment what is going on with his gene. Now, one size does not fit all. What do I mean by that? If you have a patient, a group of patients, and you treat them with the same medication and they have the same disease, some patients would have drug toxicity, some patients would have no response to drug therapy at all, and the majority of patients will have normal response to drug therapy and low toxicity. This is secondary to the genetic variation. Now, are we moving toward to the era when the patient calls us, we'll tell him, you know what, take 2 genes and call me in the room? Are we going to have a tragic genes overdose? I don't know. But all what I know, we will have a lot of genetic stuffs coming up. Now, based on that, people moved from the reference rate to the individual therapeutic concentration. Since everybody responds different to a medication, they suggested the term, why not to use the individual therapeutic concentration? Because every patient responds to the medication in a different way. And they define the individual therapeutic concentration as the range of concentration which has been empirically found to produce the optimal response in the individual patient. So every patient would have his own individual therapeutic concentration. Now in clinical practice, how can I decide the individual therapeutic concentration? You need at least two separate measurements at the steady state when the patient is well controlled. And the beauty of that, you can use the arm formation to monitor the patient respond. Should the patient have any breakthrough seizure, you can go up and check his level and make sure he is in his own therapeutic concentration. Now, what's the advantage of this? It does not rely on a fixed range, not one size fits all, and can be applied to any anti-epileptic medication, except those who has tolerance or irreversible action. What is the caveat? We assume that the medication is stable through the lifestyle, and would not be affected by changing in the protein binding or the liver disease or kidney disease, but you will always have to keep it in the back of your mind. Now, every time I talk to somebody and he called me about phenytoin, I tell him what's the phenytoin level. If he tell me, oh, you know, we did not measure it, I really, start looking at him, my God, he must have not did any neurology training. I'm doubting his certificate. But let me tell you, this is the medication. It has the best dose response curve, and it has the best documented level that would correlate with the clinical studies. And I want to show you how did they decide that this is the level that would be best for the patient. 80 patients by Bokhtar et al. Were taken. They are poorly controlled patients. At least one per week generalized tonic-clonic seizure despite using phenobarbital in combination with phenytoin. And they said, listen, when we have a concentration less than 10, 6 of them improve. When we went up to the concentration between above 10, 21 out of 27 improved. And when we went up to more than 20, some had side effect. Then the therapeutic range would be best between 10 and 20. But this is not the case. So the upper limit was also partially based on Cott et al. Work, and he said, like, you know, in patients more than with concentration more than 20, they have nystagmus, more than 13 nystagmus and ataxia, and all patients above 40, they have major side effect. Then the therapeutic level, the higher level should be 20. But in our practice, we know these are refractory patients, poorly or easy to control patients may respond at level of 5, which are excluded from this study, and people they can go up to 30 and with no side effect. So the message to take home from this study, there's nothing written in stone. Now, we only have two randomized control study on therapeutic drug monitoring and its efficacy in clinical practice. The first study was multi-center randomized control study on the clinical impact of therapeutic drug monitoring in patients with newly diagnosed epilepsy. This is in a patient who were treated with monotherapy. It was a prospective open parallel group study over 24 months, and the participants were patients both age 6 to 56. So they were pediatric patients, there were also geriatric patients with untreated partial or idiopathic generalized epilepsy and who had a history of at least 3 seizures in the previous 4 months. What did they do? They gave the patient a monotherapy, carbamazepine, phenytoin, dipakine, phenobarb, or bromidine, guided by drug monitoring versus without the drug monitoring. And 180 patients were enrolled. They found out the following: 12-month remission rate from seizure were achieved in 60 patients randomized to drug level, and in 61% of patients who are not randomized to drug level. Total of 56 in the intervention group and 58 in the control group were seizure-free during the last 12 months, it was 2 years. And adverse effects were very much similar between both groups. And of those who are randomized to the drug level, 60% completed the study, and over the 2-year follow-up compared with 60 patients with the control group. So the conclusion, there is no clear evidence to support using AED in a monotherapy in the patient who are naive to medication. However, this does not exclude the possible usefulness of therapeutic drug monitoring in special circumstances, and the most important one is polytherapy. Now, what are the limitations of the study? The limitation, very few patients were treated with phenytoin, which has the best therapeutic drug level clinical response, and also they set the power to 25% improvement in seizure, which might be unrealistic expectation. So this study for monotherapy tells you do not monitor drug level. Another one was done in 1981, and this was mainly for Apollo therapy. And the reason was to evaluate the AED level monitoring and its effect on the therapeutic clinical outcome. Total of 127 patients were enrolled, with most common seizure, grand mal, psychomotor, and absence. I don't know why you wrote psychomotor patient and psychomotor patient on medication. Plasma level for these patients were never done before. Patients were randomly assigned to group A or group B, and the plasma level for group A, 58 patients, were reported to the treating physician, and I want you guys to pay attention to reported to the treating physician. So they told the physician that this is the level, please act on it. In the group B, they did not tell the physician the drug level. The plasma level was not reported in the group B. And what did they find? They found of the randomized patient, 105 completed the 1-year follow-up, and results in 2 groups were not significantly different. Having said that, I'm going to show you one table from the study. If you look at this table basically tells you the percent of the patient who were below, within, and above. Below, within, and above before they start the study. And at the end of the study, can anybody tell me which one is group A and which one is group B? Which one we monitored and which one we did not monitor the blood level? It is exactly the same. So basically, 25% of both groups, they were subtherapeutic. 67 in both groups were within the range, and 9% were above the level. What does this mean? This means that the patient who were monitored and the information were given to the physician did not do anything about it. They told him thank you, and they left the patient. They did not use the information. So I'm not sure this study reflects the real study for therapeutic drug monitoring. Now recently we have a lot of medication that are approved in the market, and as you guys see here, there's a lot of them in the green here. They call them the 3rd generation medication, and then we're going to talk about a little bit about therapeutic drug monitoring in these drugs. Now, these drugs have a lot of different mechanisms of action. If you look here, there's so many different mechanisms of action, and some of them have a unique mechanism of action. And based on that, there's challenges in how to monitor the blood level for this medication. It has been really difficult to establish the therapeutic drug level for this medication because they were efficacious over a large range of drug levels. It has been mainly derived from a patient with refractory epilepsy, and most of these medications, when they monitored their blood level, they were more of add-on medication, and they were not used by its own. All have different pharmacological property. So for this medication, you have to assess the efficacy for each medication individually. But in general, medications that are eliminated renally, like gabapentin, pregabalin, vigabatrin, medications that are eliminated mainly unchanged, like Keppra or Topiramate, the pharmacokinetic variability is basically less pronounced and more predictable, so therapeutic drug monitoring might be not as useful. Vigabatrin has a unique irreversible action, so TTM would not apply in this case. The newer AED medication that are metabolized, like Falbamate, Lamoctal, Zonisamide, the TDM is just as relevant as for the old medication. So it might be helpful, but we're going to go ahead and talk about these medications individually. Clobazam. Clobazam, the active substance is a clobazam, and in this imethylclobazam, because of the tolerance, no clear relationship between efficacy and the drug concentration. If you insist in using the drug concentration, this is the level that you want to use, and I think basically it is only limited for complaints. You want to see if the patient take the medication or not. Lamictal or lamotrigine, it has autoinduction, and the autoinduction complete in 2 weeks. And this will result on 17% drop in the medication level. In comparison to carbamazepine, the autoinduction takes up to 4 weeks. No clear relations between serum level and the clinical response. There is significant drug interaction. If you want to use the level and you insist this is the level you want to use, and in most cases there's significant overlap between responder and non-responder, which means it might not be as helpful to do the lamictal blood level. Kebra, no major interaction. Drug level might not be very helpful for Kebra. Oxacarbazepine, no clear relation between seizure control and drug level. Tubamax, probably on Tubamax, Christensen et al. Reported that optimal response in patients with a blood level concentration between 2 to 10 milligram per liter in his double-blinded parallel group study. So in case of polytherapy, you might want to use the level in this range. Vigabatrin, TDM does not apply because it has irreversible action. This table, I put this table just to tell you and show you like each medication has factor that favor use TDM and factor that does not favor use the TDM. For example, nicosamide. If you have a liver failure or a kidney failure, you might want to use TDM. Steribintol, extensive first pass, metabolism, high serum protein binding, and zero organ elimination kinetics. So you might want to use a drug level for this patient, or for the patient who is on this medication, or in the case of a polytherapy. And this is more of a pharmacokinetic property at different strains for all AED. Now, I have been talking a lot. I am confused. Do I need to do the blood level monitoring for the patient, or do I not need to do it? Do I mainly depend in the clinical response of the patient, or who do I need to do the blood level? This is the special report about the best practice guideline for therapeutic drug monitoring in the medication. And what do they say? I'm going to read exactly what they said. Although no randomized studies have demonstrated a positive impact of therapeutic drug monitoring. And here we have to remember that one of the randomized trials, basically the information used were not used by the physician, and I'm not sure I would trust that study at all. On a clinical outcome in epilepsy, evidence from non-randomized studies and everyday clinical practice does indicate that measuring serum concentration of all and new anti-epileptic drug can have a valuable role in guiding patient management. And this rule, when do I need to do the blood level? First, after initiation of a treatment or after dose adjustment, when the clinician decides to aim at a preselected target concentration for the patient. If the patient is in a polytherapy, I added Tubamax, drug interaction, I want to keep the Tubamax in the range between 2 and 10. I might use TDM. Once the desired clinical response in a patient has been achieved, to find out the individualized therapeutic range for that patient, so I can use it later. To assist the clinician in determining the magnitude of dose increase, basically and specifically for zero-order kinetic medication, you know, phenytoin, until we reach, once we reach like a level, a desired level, any increment based on zero-order kinetic can put you in a very toxic dose, so you might want to use that. in case of zero-order kinetic medication. When there are uncertainty in the differential diagnosis of signs suggestive of toxicity or not, you are not sure, is this could be from the toxicity or could this be secondary to the medication, you might want to measure the level and compare it to the previous regimen in the same patient. When the seizure persists despite an apparently adequate dosage, compliance. When an alteration in the pharmacokinetic, pregnancy, liver disease, polytherapy, kidney disease, you might want to measure the level to make sure you are in the therapeutic range, or at least what would you consider therapeutic range. Whenever there is unexpected change in a clinical response, the patient has been very stable for years and all of a sudden he starts to have a lot of seizures, and when poor compliance is suspected. Now, I'm going to talk a few words about saliva therapeutic drug monitoring. Done?
Your time is up. So you need to wrap it up, please.
Can I have a factor of the hand? Okay. Now, this is the 10 golden rules concerning the use of therapeutic drug monitoring. If you are going to use them, you might want to use these guidelines. And if you get scared when you see this report, please do not hesitate to go ahead and use therapeutic drug monitoring. And thank you very much. Any question, comment, concerns?